Hello guys, welcome to the channel, and today we are going to talk about unstable angina. Unstable angina is a type of angina which occurs at rest, opposite to that of the stable angina which only occurs at the exertion, but the unstable angina occurs at both exertion and both at the rest. The etiology of unstable angina is the decreased perfusion of the myocardial wall. The pathogenesis include atherosclerosis, which is the main cause. Actually, what happens in the atherosclerosis is that the coronary vessels get narrowed because of some deposition, formation of the plaque, or it may be the thrombus. So this causes retardation in the blood flow to next area. So that's why decreased perfusion occurs, which led to the ischemia. Also, there can be the formation of the thrombus, or the thrombus can dislodge and become the emboli and can also go to the different places and cause stroke if it goes in the central nervous system. It can also cause the hemorrhage. There can also be the formation of plaque over the thrombus, like this. Let's say that this is the thrombus, and let's say that there is a formation of plaque over it, which led to the occlusion of the vessel. So there will be the no blood flow of the perfusion. The presentation of unstable angina is somehow slightly different from that of the angina pectoris in time. The time period for angina pectoris is 15 minutes. It do not exceed from the 15 minutes, but in unstable angina, the time period exceeds more than 20 minutes. Also, this is the angina which occurs at the rest. And if you want to see if that person having a chest pain is unstable angina or stable angina, you can see from some of these factors that the new onset angina is mostly unstable angina with having increased severity and the frequency. Also, the sudden change in the pattern of the angina is suggestive of any physical changes in the coronary arteries such as hemorrhage, thrombus formation, or the plaque dislodge. And this last one is very dangerous, as the plaque can go to the other parts of the body and can as the plaque can go to the other parts of the body, and maybe it can lodge there and stop the blood flow to the necessary parts of the brain, which led to the stroke. So in this picture you can see that there is a plaque in the coronary artery which is causing the narrowing of the artery, and so the blood flow is reduced. Here you can see that, and this is the plaque in the yellow, and this is the original space, and now this is the narrow space, so reduced blood flow. It's seen that the 35% of the patient who come with a complaint of the angina already have coronary thrombus, which is exaggerating the process of chest pain. There are certain tests by which we can differentiate between unstable angina and MI. MI is the myocardial infarction. The simple thing is that we can do the ECG, but on ECG there are two types of MI. One is STEMI and other is unSTEMI. We can see the ST segment elevation on the MI of STEMI, but in non-ST segment elevation there is no elevation of ST segment. So picture of unSTEMI is similar to that of the unstable angina. So that's why we do the cardiac enzyme test, troponin and CKMB. If these enzymes are elevated, then it will be MI. So whether it will be STEMI or unSTEMI, cardiac enzyme is the best thing to differentiate MI from unstable angina. Now we will talk about the clinical feature of the unstable angina. The first and foremost seen clinical feature of the angina is the chest pain, which is radiating towards the head, jaw, arm and shoulder and the back. Also, the patient can also experience the chest tightness, squeezing and crushing. And the main factor which separates it from the angina pectoris or stable angina is this: angina at rest or discomfort at rest. Patient may also experience shortness of breath. There can be the sweating. Patient can also experience the symptoms of the epigastric pain and the vomiting. And keep in mind that these two symptoms are related to acute pancreatitis also. So if the patient come to you with only these two, then don't label them as acute pancreatitis. It can also be the case of unstable angina. So you have to check for the other sign and symptom, ECG and other things. So that's a clinical picture. The patient can feel weak, dizzy or lightheadedness. It is because of the decreased perfusion, coughing or wheezing, an overwhelming feeling of anxiety, such as having a panic attack, shortness of breath, chest pain, sweating, feeling of being sick, and pain in other parts of the body such as left arm, jaw, neck, back, and abdomen. This is all due to the radiating pain, as chest pain is radiating to the other parts of the body. Keep in mind that in diabetic patients, the disease is somehow silent because the diabetic neuropathy had destroyed the nerve system. So that's why the patient do not experience as much pain, but it occurs in often less people. Also, if due to the unstable angina, ventricular fibrillation start, the patient won't go in the MI and die. If the ischemia is severe somehow and it cause a stop in SA node firing, then this will lead to the death of the person by asystole. So now the main thing that we study in the medicine is the diagnosis. The diagnosis is commonly based upon the physical exam, which is normally in most of the patient appears normal. Then after diagnosis, the best and the most handy, easy and cheap test is ECG test, in which the so after physical exam we will go for the ECG. In ECG, if there is ST and T wave abnormalities, then we will label it as the unstable angina. But we have to go through other tests too, such as stress test. It is also called ECG stress test. In this, the ECG is done during, before and after the stress, and the reading is taken. In this test, it is common. What we do in this test is we see if there is any ischemia occurring to the body during the stress or not. It can be of the physical or the chemical stress. In the heart rate is achieved up to the 85% of the maximum predicted value of the age, and then it will be calculated as 220 minus age, as 220 is the highest blood pressure, okay, predictive value of the age, and then 220, and then this formula is used to get the blood pressure. Let's say there is a person whose age is 20, then the heart rate that he have to achieve to show correct response in the ECG stress test is 200. Chemical stress test or pharmacologic stress test is also used if the person is not able to do the physical activity. In this process, the diparatimol or dobutamine are used, or we can also use the adenosine. And dobutamine actually increase the oxygen demand by increasing the heart rate, increasing contractility, and increasing the blood pressure of the patient. Finding actually what happens on the exercise stress test is exercise induced ischemia or subendocardial ischemia occurs, which leads to the ST depression on the ECG, and this is suggestive of the ischemia. The onset of the other findings which are suggestive of the positive test is onset of heart failure, ventricular arrhythmia, or the hypotension. Okay, then now we will list the some things which, so these are some conditions in which exercise stress test shouldn't be done, which is left bundle branch block, pre-existing ST changes. As if the patient already have pre-existing ST changes, so how will we interpret the ECG ST segment depression? So it's not done in those patients which have pre-existing ST changes. The left ventricular hypertrophy, the patient with a stress test should go for cardiac catheterization, so we can do intervention and deal with them. So this is a, you can see this is a patient on a treadmill with electrodes and the blood pressure cuff attached, and here is the ECG monitor which is recording the ECG of the patient while he is doing physical activities. So what is done in the cardiac stress test? First, vitals are taken such as ECG, blood pressure and the pulse rate and Meyer. Then the patient begins walking on treadmill. Vitals are recorded every 3 minutes as treadmill intensity increases. Patient have to exercise until reaching or nearing the maximum heart rate that we have calculated, the 85%, 220 minus age of the patient. So we get, and then gradually patient will cool down. Stress echo is another type of the exercise test in which exercise induced ischemia is detected by wall motion abnormalities such as akinesis and hypokinesis, which are not usually present at the rest. In stress echo, the echocardiography is done of the patient instead of the ECG. This is more sensitive than the exercise stress test or ECG stress test in detecting the ischemia. This is more sensitive than the ECG stress test in detecting the ischemia, as by this we can assess the LV size and the function, which is left ventricle. Also we can diagnose if there is any valvular disease. Also we can check if there is, also it can be used to detect the coronary artery disease with pre-existing ECG abnormalities in the patient. Okay, now let's talk about the in which patient it is less reliable to use echo stress test, in which the pre-existing wall motion abnormalities, then it will not be used. If this appears positive, then we will do further cardiac catheterization. So this is a picture of the patient walking on the treadmill and the electrodes are attached to him, and this is the echo picture of the patient. Stress test is used to confirm the diagnosis of the nature of the patient's disease. It is used to evaluate the response of the treatment and identify the coronary artery disease risk. There is also another test which is called the nuclear stress test, in which thallium-201 is injected into the body, and this is taken up by the healthy myocardial cell. In this test we check the myocardial perfusion. So the radioactive tracer is injected through the IV line and patient lie under gamma camera for 15 to 20 minutes while the images are taken of the blood flow to the heart. Then patient go on a treadmill, begin walking. Electrodes are placed on the chest for ECG. IV line started, began working on the treadmill, and the vitals are recorded. Then near maximum heart rate, radioactive tracer delivered through IV. Patient lie under gamma camera for 15 to 20 minutes while images are taken of the blood flow. Actually, what happened here is that the viable myocardial cells uptake the radioisotope, so they can be detected in the imaging, while in those cells which are not viable, no radioactive isotope is taken up and the no blood flow is there. Something about the nucleus test, which is that it is expensive and it includes the radiation which most of the patients do not prefer, and it is contraindicated in the left frontal branch block. So in the patients With stress test, we should check if the ischemia is reversible or not. If it is reversible, then we can arrange the specific measures to reperfuse patient by the PCI or CABG. Otherwise,